I'd like to welcome you to the 2018 Department of Psychiatry graduation address. The Grand Rounds presentation that you will hear today will kick off the day full of graduation activities that is just a way that we can acknowledge the accomplishments and connections that have been developed over the 4 years for our extremely talented and hardworking graduating class of psychiatry residents. We're extremely proud of all of you and thrilled for both what you've done, but excited about what you will do. And today's graduation address is intended in part to help us think about that process. Just a few housekeeping things. Next week, we don't have a Grand Rounds. The following week, Paul Tahiri is going to come and be talking with us about the development of Yale Medicine, the faculty practice for the medical school, and that should be both very informative and useful for folks. I have the great honor and pleasure to welcome back to Yale our graduation speaker, Dr. Glenn Gabbard. Dr. Gabbard is clinical professor of psychiatry at Baylor. He's a training and supervising analyst at the Center for Psychoanalytic Studies in Houston and professor of psychiatry at emeritus at SUNY Syracuse. Dr. Gabbard was at Northwestern University from 67 to 69. He was at UT Austin from 69 to 71 and graduated in 1972 with a degree in theater arts. And we spent a lot of time at dinner talking about the theater because he's written extensively about the interface of psychiatry and the theater, and it turns out he comes from a theater family and that's been very much of his life and become part of his career. He graduated from Rush Medical School in 75 and then went to Menninger's for his residency and completed psychoanalytic training at the Topeka Institute for Psychoanalysis. His initial clinical appointment was at the Department of Psychiatry at the University of Kansas, where he rose to the rank of clinical professor. And then he became the Bessie Walker Calloway Distinguished Professor of Psychoanalysis and Education at the Carl Menninger School of Psychiatry and Mental Health, and was there until 2001 when he moved to Baylor. He became professor of psychiatry and then the Brown Foundation Chair of Psychoanalysis at Baylor, and was also professor of psychiatry at SUNY Syracuse from 2011 to 2015. Along the way in this incredibly accomplished career, he's held a number of important positions. He was the director of the C.F. Menninger Memorial Hospital, vice president for adult services, director of the Topeka Institute for Psychoanalysis, director of the Baylor Psychiatry Clinic, and he's held a number of very important editorships, most notably editor-in-chief and editor for North America of the International Journal of Psychoanalysis. And he's an editor or a member of the editorial board of 22 other journals and publishing related activities. One of the things that I've enjoyed talking to him about last night and this morning is about how you have a career in writing, because writing is a part of so much that we do, whether it's progress notes, papers, curricula, books. And I think that there is no better model of someone who has made writing an important part of their life and career than Dr. Gabbard. He's written 28 books, 452 publications, and these are just a few of his books. There isn't, if I put all 28 books on the slide, the font would be so small you wouldn't be able to read any of it. But he's written and edited books like The Psychodynamic Psychiatry and Clinical Practice, The Synopsis of Psychiatry, which is the usable version of the Kaplan and Sadak book, Treatments for Psychiatric Disorders, which is now in its 5th edition, which is a seminal contribution to the field, as are his books on psychoanalysis, like Boundary and Boundary Violations in Psychoanalysis, Long-Term Psychodynamic Psychotherapy, and the American Psychiatric Publishing Textbook of Psychoanalysis. There's probably no more authoritative voice, and I mean authoritative from the perspective of being a useful resource, not authority figure. But there is no more important authoritative voice in psychiatric, writing about psychiatric clinical practice than Dr. Gabbard, and this depth will be very evident in the presentation that you hear today. His writings cover an enormous range of topics, and I'm going to just touch on a few. And this is what I mean about small fonts that you can't read. So, but a lot of his writing has to do with what it means to be a psychotherapist, what it means to be a psychiatrist, about the relationship between doctors and patients, about trying to understand how to harness that relationship in therapeutic ways. And one of his papers, which I think will emerge in the talk today, is the role of compulsiveness in the physician practice. An interesting and graduation-relevant area of his contributions are his writings about the relationships, the marital relationships that, and romantic relationships that physicians and psychiatrists have. He's written about treating couples where both members of the couple are physicians, and that relates in some ways, I think, also to his work on boundary violations as well. He's written a lot about the challenges of having a career in psychiatry or psychoanalysis. Books like, or papers like The Lovesick Therapist, Patients Who Hate, The Big Chill, The Transition from Residency to Managed Care Nightmare, and the seminal How Not to Teach Psychotherapy. He's written in so many areas. I'm just going to touch on a number of areas where he's made really important contributions, like in the area of narcissistic personality disorder, psychodynamic perspectives on the cinema, and also near-death experiences and dissociative states, which I think is a really underappreciated and important area of study. Again, how do you capture 163 major honors, plenary lectures, named lectureships? I thought I would start with the Sigmund Freud Award. I think that's probably a very high award for the American Society of Psychoanalytic Physicians. Also, the Edward Strecker Award from the Institute of Pennsylvania Hospital, which is one of the longest standing and most prestigious awards in psychiatry. He's been a plenary speaker for the American Psychoanalytic Association. He's received the Mary Sigourney Award, which is from, I believe, a independent foundation, which is also an extremely prestigious award, and many, many other awards. The Adolph Meyer Award, the Henry Page Laughlin Award, and the APA's Vestermark Award for Education. And then I think particularly relevant are the fact that he has been honored nearly every year, or certainly most years, by the trainees and fellow faculty members at Baylor with an outstanding teaching or supervising or mentor award in that department. So I think that there's no better person to speak to our graduates, their family members who are here today, and our department about this pivotal moment when you set out to create your career and create a life that encompasses that career, than our graduation speaker today, and I'm extremely pleased to welcome Professor Gabbard.
Can you get the want to make sure I got my slides on here.
I think we can just close this
Close
down.
that, and then we should be able to get mine. Let's see.
Yeah.
Mine or, let's see.
I think, is it that one?
No, I think it's down here. Well, I can find it for sure here. It's in the documents.
Are you not
Oh.
down there? Did they close it? Did you close it out?
Close this one out?
Did you close it out
No.
here already?
Oh, is it here?
That's where it was, but let's see. Go to Yale.
Yale lecture, that's it. Okay. Yeah,
Over
and
here.
then we do this. Okay.
There.
Now we're in business, I think. Okay, thank you. Well, thank you for that wonderful introduction, John. I don't know if I'll be able to live up to that. I'm kind of nervous now about trying to make that seem like it's real, but I appreciate the fact that all of you have shown up, and you know, it really is an honor to be asked to serve as graduation speaker. I did it once a few years ago, and it was a lot of fun. And I was saying last night to those who took me to dinner that you really know how to make an outsider feel like part of the family, and I'm grateful for that. It was a great time. I've chosen for my topic the obsessive compulsive physician, and much of my life has been devoted to treating physicians and psychiatrists, and I think the message I'm trying to bring home today is that one of the things about us as psychiatrists is we're always thinking in a dual way of what's going on with this person who's my patient and what resonates in me about this person, because we're more similar to our patients than different. You know, this is a very important aspect that we recognize. As some would say, there are two patients in the room. Each of us brings our own background into the room, and we're responding to one another. And one of my mentors when I was starting out at Menninger, an Israeli psychoanalyst named Dov Alexandrovitz, taught me something very important. He said, we don't simply learn about it, you have knowledge, and then go treat patients. He said, we treat patients to learn about them and learn about ourselves. So that's kind of the spirit of today's talk, and we'll talk about what you all can be thinking about in terms of your own tendency to be compulsive, because almost anyone who gets through medical school has to have some compulsiveness. And then also how we help patients who come to us with that, because you all will probably treat many doctors just as I have. Let's start with medicine as identity. It's not just a job, it's a calling for most of us. And being a doctor is often at the core of who we are. And one of the things I've seen in my career is physicians who stop working or retire often have terrible time. They lose a sense of purpose, a sense of self. About 30 years ago, I lived next door to a general practitioner, and he turned 70 and he retired, and I stopped hearing from him for a while, but one day I was working in my yard and he came across the street and said, Glenn, I've got some advice for you. Don't ever give up your license. And I said, oh, really? And he said, to be blunt, for the last 6 months since I gave up my license, I keep thinking about blowing my brains out. He was dead serious. He was suicidal. And I said, well, have you seen a psychiatrist? And he said, yes, I'm seeing one now, and I've talked to the board about getting my license back, and I'm going to work in an indigent clinic, which I know will give meaning to my life again. This guy did something to save a real tragedy, but he was so candid and so blunt. I wanted to start with that because this is the way some people can decompensate without that feeling of the identity. Now, there's a paradox that the psychological characteristics that make for a good physician also make it hard to stop working. Many physicians are compulsive workaholics. Not all, You see other various characterological features, but this is a common phenomenon, and I'd say that most of us who are in this field have a need to be needed. I'm going to tell you about my background in getting into this. When I was maybe a couple of years out of the residency, Roy Menninger and I started a series of workshops in Colorado in the summer called Physicians and Their Families, where we'd sit with groups of physicians and often spouses, and we would talk about what it's like to be a physician. And from that, I had 3 publications, The Role of Compulsiveness in the Normal Physician. I published that in JAMA in 1985, and I've got hundreds of reprint requests, far more than I've ever gotten before, because I think it touched a nerve in people. And The Psychology of Postponement in the Medical Marriage. This is a huge problem of postponement of pleasure, activity, plans until it's too late. And then Roy Menninger and I then edited a book on medical marriages. Following that, I started a professionals in crisis unit at the Menninger Clinic, because at that time there weren't very many places that physicians could go to get help, except drug rehab places. And so we started that unit at that time, and it's still going. And then because I kept getting so many requests for evaluations, I started a team of multidisciplinary evaluators for impaired professionals and mainly physicians. And when I moved to Baylor, I was the director of the Baylor Psychiatry Clinic, where we continued doing multidisciplinary evaluations. And some of you may know Mike Myers at Downstate, SUNY Downstate, and he's an expert in physician suicide, and he and I wrote a book together on this subject. So this has been very near and dear to my heart for years. My first day of medical school, the chairman of internal medicine came to see the first-year residents, and he said, the most important quality of the physician is compulsiveness. And in a way, he has a good point. He said, if any of you get sick, you want a compulsive physician who checks and double checks lab data, who thinks about the zebra conditions that other people might not think of, and who makes rounds, if you're in the hospital, once in the morning and once at night, and really is in there trying to figure out things for you. And he's right, that's the kind of person we would want, but that's gotten to be a problem in so many ways. And there is a psychological vulnerability of physicians to try to be too perfectionistic, never make a mistake, and it leads to all kinds of difficulties in physicians' lives. And you'd say society's meat is the physician's poison for that reason. Now, let's just go over the criteria, because I want to make a point here. I'm primarily talking today about OCPD, the personality disorder, not OCD. And I want to specify that the sorts of things that I'm focusing on in the criteria. First of all, preoccupation with details, rules, lists, order, organization, or schedules to the extent that the major point of the activity is lost. And you'll see people who are always making various kinds of notations in their iPhone or their iPad or whatever, and organizing things to the extent that you can't really get the work done. And often the point is lost. And this is closely linked to the second point, perfectionism. There's some fantasy, I think, in many of us that we can figure out a perfect way to run our schedules, to treat patients, and this leads to a difficulty in completing tasks. One of the things I was talking to John about, and I've mentored a lot of people who want to write, and perfectionism is one of the worst enemies of writing. People will have 72 drafts of their paper and they're still not satisfied. And one of the hardest things that I do as a teacher and mentor of people who want to write is say, just put your ideas down quick and dirty. Just get it on the page, type it or dictate, whatever you want to do. but get it down there. You can shape it up later, but the perfectionism really gets in the way. And also, I would say, it gets in the way of optimal care if you're always trying to be perfect. And that's a paradox, because a lot of people think a physician should be perfect and never make mistakes. Now, another one that I think is an occupational hazard is excessive devotion to work and productivity to the exclusion of leisure activities and friendships, not accounted for, of course, by obvious economic necessity. One of my colleagues at Baylor, Mark Koenig, went to medical school at Baylor, and he said when he started there, the great heart surgeon Michael DeBakey was the godfather at Baylor. And he said on the first day of their medical school class meeting, he came in front of all the first years and he said the following: "From this day on, you must get rid of all your hobbies, all your leisure time pursuits. All of your pleasure will come from the practice of medicine." So, you know, the whole class is writing that down and highlighting it with their yellow highlighters and saying, okay, no fun, no time for people, just do the work, and that's where all your pleasure comes from. But, you know, that sort of forceful statement by an icon of heart surgery, it has a powerful effect. And, you know, this next cartoon captures this, honey, you're sleepwalking again. But this is a problem, though, that people with electronics are losing a lot of sleep, working way over time. The next one is over-conscientiousness, scrupulousness, and inflexibility about matters of morality, ethics, or values. Now, this one is underplayed, but it's very important. Everybody in this room has been in a case conference, a committee meeting, or some such meeting where after a discussion of a patient or an issue, somebody sitting around the table says, am I the only person in this room who is concerned about the moral and ethical dimensions of this? No one seems to be talking about the ethics of this. We're just talking about what the treatment should be. Shouldn't we also be thinking ethically? And of course, while that person is saying that, everybody else is rolling their eyes and, you know, thinking, oh, right, you're more ethical than the rest of us. We hear you, you know. So there's a kind of scrupulosity which can sound very condescending and really turn off people. This happens a lot to obsessive compulsive perfectionists who think, I'm trying to do this in the best way, but they're turning off everybody around them. So, you know, when you're treating obsessive compulsive people, you're focusing a lot on the interpersonal ramifications of being that way. Now, the last page on the criteria here, I think I would sort of ignore these two. I think 5 and 7 should have been thrown out, but there was a huge political hassle in the DSM team working on personality disorders, and that I won't go into that, but anyway, number 5 basically should be under hoarding, you know, inability to discard worn out, worthless objects even when they have no sentimental value. And I don't think in my career of seeing many OCPD patients that hasn't been a very prominent issue. And number 7 about the miserly spending style, that goes back to Freud's anal retentiveness ideas, and basically you don't necessarily see that with OCPD, and I'm not sure that should be there either. On the other hand, number 6 is very important, reluctant to delegate tasks or to work with others unless they submit to exactly his or her way of doing things. So another reason besides perfectionism that people don't get things done is they're control freaks. And the OCPD people want it done a certain way, and a lot of times they say, to hell with it, I'll do this myself, because when I try to delegate, you don't get it right, I'll just do it. And then they have way too much work because it has to be done in a certain way, and they can't be flexible. And rigidity is a very important one too, rigidity and stubbornness. Now, one that isn't in there, which I think is very important as a clinician, is obsessional over-inclusiveness and overthinking. That's a real common dimension of people with OCPD. And often they have a kind of, let me put it this way. OCPD people are all about data, information, not feelings. So they'll tell a long-winded story trying to get all the different ramifications and data in there. And the person may be yawning that they're talking to, and they say, well, just a minute, I've got to get everything in, though, to give you the full picture. And they're, again, kind of turning people off without noticing it. And often, when you're doing therapy with someone like that, it becomes a challenge to hang in there and listen to what they're saying. And you have to find ways to interrupt and put yourself into the room. Now, overthinking is a variation on this, where everything is thought through to an extent that can kind of be, make others furious, or it's focusing entirely on a non-affective aspect of whatever is going on. I treated a resident years ago who was in emergency medicine training, and he had this overthinking problem. I'll tell you a brief little vignette that captures this perfectly. We'll call him Bill. We'll call the woman ER resident Sadie. So Bill and Sadie left a very difficult night in the emergency room. They're walking to the parking garage, and Sadie says to Bill, "Man, that was a difficult night. I'm glad you were there. We got through it, didn't we?" And he said, "Yeah." So then she sat down in her car and said, "Good night, Bill. Love you." Now, the next day, Bill was talking to me, and he said, "I froze when she said, 'love you.'" And I didn't say anything. Now I hate myself because I didn't say anything, but here's what I thought. If I say "love you" back, is she going to think that I want to have a romantic relationship with her? And then I thought, she's gay. And will she think that I am, by saying "love you," I'm trying to get her to become a heterosexual so she'll have a relationship with me, which of course isn't what I want at all. And then I thought, well, how does she mean love? Because love has so many different definitions. And I was sitting there paralyzed. She'd already driven off by this time. I was thinking, now, should I write her an email and explain that the reason I didn't say "love you" is because I wasn't sure how you would take it. And then I interrupted him and I said, "Well, Bill, I think that you are probably thinking about this much more than Sadie is." And he said, "Well, I'm also kind of worried, as you know, Dr. Gabbard, I'm worried about, am I what a man is supposed to be? And I'm thinking, what is the macho way to do this?" I said, "What do you mean the macho way?" He says, "Well, you remember in the second Star Wars movie, Empire Strikes Back? Well, when Han Solo is about to go down into the freezer, Princess Leia says, 'I love you,' and Han Solo says, 'I know.'" And I said, "Now, Bill, I'm not sure that Han Solo would be your best role model for romantic relationships, First of all, we're not in a galaxy far, far away. And he's kind of a lone wolf who hangs out with Wookiees, He's not exactly somebody who would be a good role model." And he laughed with me, and I said, "Yeah, I know, but I can't stop thinking about what I should do." And this humorous account shows how tormented he was, though, about what is the right thing to say. He finally did send her an email in which he tried to explain some of this, and of course she was very gracious, and they continued to be friends. And I pointed out, you worry about this a lot more than you need to in terms of potential impact. The worry takes up a lot of your mental energy. And anyway, that's another real problematic issue of this picture. It's the most prevalent personality disorder in the general population. You see it everywhere in 7.88% in the Grant study of 2004. And in my work, I describe a compulsive triad, which I think is really useful for the clinician. self-doubt, guilt feelings, exaggerated sense of responsibility. The self-doubt part almost always accompanies compulsiveness. And one time I had a neurologist sent to me. He was an academic neurologist, and the reason he was sent to me for evaluation was he took forever to make rounds. He'd have a resident with him, an intern, and like 3 medical students, and he'd go into the patient's room, and I heard the complaints from the students that were with him. They would send them to me, but they didn't want to say it to the professor, you know. So here's what would happen. He would come in the room, and you know, this is a woman's foot, and the woman's lying in bed, and he's wondering if she has a Babinski, and he takes his reflex hammer out, and he goes, did that toe go up or not? Let me see. What do you think? And the resident would say, oh, I don't know, sir, but, you know, do it again. And according to the students that were with him, he would sometimes do 20 Babinskis because he kept doubting himself. And then, you know, what would happen is then the resident would come do it, then the 3 medical students and the intern, you know, and the sore foot, you know. And the patient was not happy about it either. And going from room to room, rounds took most of the day, and a lot of the work didn't get done, so that's why he came to me. He knew he had the problem, but he said, I've just got to get it right. There you hear that perfectionism too. Here's a good cartoon. From 3 a.m. to 4:30, I have you wondering if everything in your life has been a mistake. And a lot of OCPD people have that kind of constant doubt that they haven't done what they should do. Guilt feelings is another part of this triad, very common. And I'm sorry, I wanted to show you this too. No, that's not a sin either. My goodness, you must have worried yourself to death. This is the guilt cartoon that St. Peter is trying to make him easy on himself. Now, guilt, though, is something that stays and stays like becomes a permanent part of a kind of harsh superego that's unrelenting. And, you know, I remember one of the saddest stories I heard. I saw a 62-year-old general practitioner, and I was kind of taking a history of him. And he said, I know I killed one patient. I said, what do you mean you killed a patient? Well, he had a sore throat. In those days, you injected penicillin for a sore throat. I think he had strep. And he had a horrible anaphylactic reaction, fell to the floor, and in 2 minutes he was dead. I have that picture in my head, and I can never get it out. And I said, well, did you ask him if he had a penicillin allergy? He said, of course I did. He said he didn't. And I've been haunted by this. He said, I spent 100 hours in the medical library reading on anaphylaxis, penicillin, trying to somehow figure out what went wrong. And I can see it like it was yesterday. And this guy was just, you know, in so much pain because this was right there with him, that he had failed in some horrible way. The third type is exaggerated sense of responsibility, and that's very much involved in OCPD, where there's always a sense that you have to be responsible, and other people can't do it. You can't delegate to others. It's your responsibility. Here's a guy on vacation. Can't you ever relax? This is Sisyphus on the beach. Now, one of the things I want to take us through at this point is what we mean by OCPD versus OCD, because I've realized that there are very senior, intelligent, well-trained clinicians who don't really know the difference. And they're often used interchangeably, and they're quite different. And I think this relates back to Freud's early writings, like in The Rat Man, where he was linking the characterological aspect, with the obsessive compulsive neurosis, as he called it. That's been confusing because now obsessive compulsive neurosis has disappeared and been replaced by OCD. OCD is characterized by ego dystonic need to perform rituals and think certain thoughts. OCPD is characterized by egocentric personality traits, and that's quite a significant difference, although they sometimes co-occur. There was an excellent study that came out, I guess 4 years ago by Pinto's group, and they looked at 100 patients. 25 had OCD alone, 25 OCPD alone, and then 25 with both, because you do see them co-occurring, and 25 healthy controls, which is a nice distribution for the study. And what they found, both groups had some impairments in their psychosocial functioning and quality of life compared with controls, which we would expect. But the OCPD patients did not report intrusive thoughts or images. That really nails it to OCD. But they reported ritualized, methodical behaviors like list making, organizing belongings, editing written work repeatedly. All of us do a lot of editing of written work, but some OCPD people can't get any writing done because of what I was telling you about the perfectionism. OCPD patients were better at delaying reward than OCD patients. I mean, the obsessive compulsive doctor is a master at delayed gratification, Maybe not voluntarily, but that's what it ends up being. And this ability to delay was linked to perfectionism and rigidity. Now, OCD is, characterized by hand-washing rituals. That's very much OCD and not OCPD. And Pinto and his colleagues concluded the two disorders are related but not the same thing. Only OCD patients have true obsessions that they can't get out of their minds. And OCPD patients, as I mentioned, delay reward much better. Now, here's another thing you'll hear in conversations about patients in psychiatry. Someone who has sex addiction will say, I have OCD. Now, as Ben Greenberg, an OCD expert at Brown, says, so-called sex addiction is not OCD. If it feels good, it's not OCD. And that's kind of a nice thing to remember. And actually, I asked Ben about that, and he said he actually stole that from Rudolf Hohn-Sarin at Hopkins when he was a resident. So it has a long history, but it's a nice little thing to remember, because if something is feeling good, it's not OCD. The treatment of OCD is pretty straightforward: exposure in vivo plus response prevention. SSRIs help too, as we know. And in these studies, they maintain improvement for up to 3 years follow-up. And the only place you'd use psychodynamic therapy would be if somebody was not complying with medication and you wanted to understand the reasons for that, or the relational aspects of it. But primarily, it's not a psychodynamic condition that you want to use that for. Now, if we switch to OCPD, we know that dynamic therapy works very well with lots of OCPD patients. There used to be that the anal phase that Freud identified as part of this. My experience in 40 years of doing this is it doesn't go very far with most patients. It's not very useful. The things I work on are self-esteem issues, the terrible fear of feelings, affect phobia, perfectionism, interpersonal problems, the absence of fun and pleasure in their lives, balancing work and love. These are the things that are usually occupying the time. And they often bring you a history that, whether it was true or not, they perceived that they could not please their parents. They're only valued for what they did, not who they are. You also see that in some narcissistic personalities. Intimacy is threatening because it carries with it the potential to become out of control. And one of the things that will help you make a connection with an OCPD patient, if you recognize, I know you fear being out of control, because they'll feel somebody understands me. That's the thing that makes them so tightly bound, that they're going to lose control in some way and make a fool of themselves. The need to control others stems from a fundamental concern that sources of love and support, like parents, are highly tenuous, may disappear at any moment. So they get very worried about, if they don't control somebody, then they'll leave them. Low self-esteem, connected to not being valued as a child, and this basic fear. Anger and destructiveness will drive others away, so I can't show that. But what happens is it becomes a passive-aggressive version. Like the over-inclusive person can make a lot of people irritated by trying to be complete in what she's talking about. Now, affect phobia is something I work a lot about. Like I keep saying, like when I'm treating OCPD patients, I'm often saying, yeah, I hear the data, I hear the information, but I don't get what you feel. And the patient says, I don't know what I feel. I said, okay, well, let's sit with it a while. Let's think about what you might feel. And try to start getting into that, and then talk about the fears of losing control, if they have feelings. And, you know, there's a lot of pride that many obsessive compulsive physicians take in that I always keep my emotions in check. I don't lose it in the OR. You know, that's one of my strengths. And I remember having a very poignant case of a middle-aged pediatrician who was sued for it was a nuisance suit, because he was one of the best pediatricians around, but something happened in the ER and he got sued, and he was mortified, but he couldn't talk about it. And what he did say is, when I go into the doctor's lounge, I'm afraid everybody is staring at me and thinking, how did I screw up, you know? Like, what did I do wrong? And I said, I doubt if they're thinking that. And I said, now, do you talk to your wife about this? No, I don't think she'd understand. I said, can you bring your wife in? I'd like to talk to both of you. So she came in the next time. And I said, does he share what he's going through with you? She said, he's very quiet. He just wants to watch the news when he gets home. And she said, here's what he does. He brings in the deposition, he puts it on the kitchen table and says, read that. No emotion, no discussion. He wanted to keep it very contained. And so what I did was, it was wonderful to have the spouse there so he could hear this kind of feedback from her. And I said, you've got to start talking about it. And he started in that session and continued. But that's a lot of what you have to work on. He said, I think she knows my feelings. That's why he said he didn't have to talk to her. She would know it by mind reading. That's often part of the issue. So the impact on family, partners, loved ones, that's a huge part of this. That the interpersonal dimensions is what you spend so much time working on. Sometimes I wonder what life would be like with you. Our marital problems can't be my fault. I'm never home. Here's one of my favorites. Dad, here's that update on my childhood you requested. Now, see, one of the problems with obsessive compulsive people, they want to do things perfectly. So they want to be the perfect parent. And one female dermatologist who I think was actually a very good mother, but always worried that she wasn't being, what she would do is after dinner, she would have family conference. And she had 2 boys and a girl, and we'd sit down in a little circle, and she said, well, let's go over each of your days. What did you do? And do you have homework assignments? And she was being very organized, and the kids are going, okay, yeah, we'll do the family conference, and they try to look away at the TV or something. But they felt they were kind of being controlled to do this, but to her it felt like, I'm being a good mom and I'm controlling things. I'm in contact with them, and the kids had different ideas about it. This gets into perfectionism, and I think the starting point on perfectionism is, yes, it's part of OCPD, but it's culturally ingrained in us. Every 4 years when I see the Olympics, I think, my God, we all buy into this perfectionism stuff. I remember, I think it was the last Summer Olympics, there was this outstanding U.S. gymnast. She was 14 and incredibly talented. And she was thought to be the person that was going to win the gold medal. So in the competition, she came in 3rd and got the bronze medal. And I was sitting there watching the Olympics, and the sportscaster, with not a note of irony, but with absolutely seriously, said, it is a tragedy of major proportions that this girl had to settle for the bronze medal. And I'm sitting there as an audience member thinking, you're the third best in the world? And that is a tragedy of major proportions? But you can see the whole culture thinks that way. It's not just a sportscaster, he's speaking for a lot of people. And one of the things that you have to do as a therapist working with OCPD people is constantly work on the perfectionism. And one of the things I always say to patients, you know, if you were perfect, you would have no friends. Nobody wants to be around a perfect person. It's terribly annoying. And so, you know, you might as well start thinking about lowering your sights. And, you know, I always say, think about excelling or being excellent instead of perfect, because you're going to make mistakes. And, you know, we have a growing body of literature on perfectionism now. It's a vulnerability factor for depression, burnout, suicide for sure, and anxiety. Now, there's another one that's not up there, but eating disorders. Also, perfectionism, very closely linked to that. Now, I was not involved with this case, but I just read about it in the press. Dr. Jonathan Drummond Webb, he was a University of Arkansas Medical Center heart surgeon who was kind of a young phenom, and he committed suicide at the age of 45. Now, I don't know much about it, but I noticed this in the press. The CEO of the Arkansas Children's Hospital said this: some would say they saved 98 out of 100. He looked at it and said, I lost 2 out of 100. That's the kind of perfectionistic thinking that you have to watch out for. Everybody is going to fail on some cases. And I think he saw that as a sign of, I failed to be perfect and I can't live with myself, you know. So this is a very important principle as you graduating residents go out into practice, that you're gonna blow it sometimes, and everybody does. We can't do a perfect job. Voltaire once said, the perfect is the enemy of the good. That's a very good quotation for you all to remember, because, you know, if you're a perfectionist, it robs you of the sense of, I've really done a good job today, if it's less than perfect. And you want to have that capacity to think, I've done something good. In Flett and Hewitt's work, they said that there's often this problem. Others will value you only if you're perfect. And that's associated with both depression and suicide in their studies. There's an element of pressure associated with helplessness, hopelessness. And then this one I hear all the time from patients: the better I do, the better I'm expected to do. I'll just raise expectations by my parents, my partner, my friends, and everybody. And there's this intense need for external validation. Again, another overlap with narcissistic personality. The two do have some connection, I think. Now, here's another tragedy about it. OCPD persons rarely seem satisfied with any of their achievements. You know, there's some lack of a good feeling, again, because of the horrendously harsh superego. I still haven't done enough. I once had the privilege of having dinner with a Nobel Prize winner, and I'm not going to mention his name, but I was just chatting with him at dinner and said, well, now that you've got the Nobel Prize, what's on your agenda for the next project? And he said very seriously, I'm just racking my brain thinking of how I can win a second one. And I was kind of speechless. I didn't know what to say. And, you know, I thought, well, this is sad that one isn't enough and he's going to have to spend the rest of his years trying to make a second Nobel Prize win, or he's failed. So, you know, this is something, too, that we want to be very thoughtful about when we're treating OCPD people. They may be setting themselves up for a life of misery by having those kinds of expectations. And, you know, sometimes you feel that the wish is to gain relief from a tormenting superego rather than a genuine wish for pleasure. And here's something I found very useful that I want to pass on to you. The notion that there is an imaginary audience. You all can relate to that, I'm sure. Most OCPD people think, people out there are watching me and judging me constantly. And, you know, this is a kind of, obviously, externalization or projection of this harsh superego. Everybody's critical of me when they're really not. They have very little evidence for it, they just assume that. And not long ago, I had a 34-year-old surgeon who was supposed to go to his kindergarten child's little program at 9 o'clock on a weekday morning. And he says, I'm just struggling with whether I should go or not. I said, why wouldn't you go? These kids are going to grow up fast. This is a chance to see your kids, you know, in the kindergarten program. He goes, well, here's what he said. I worry what people are going to think about me. I said, what will they think about you? He said, they'll wonder, you know, why am I not in the hospital? Why am I not operating? And, you know, the people who at the hospital will be thinking, where is he? And the people at the kindergarten thing who know who I am, they'll say, what? You know, is he goofing off? And I just said, wait now. First of all, none of those people at the kindergarten event are going to be thinking about you. They're watching their little kid and thinking about themselves. They're not thinking about you. And he kind of laughed, and the humor helps a lot in this situation. And so he did go, but it's a real common thing that you run into, that it's this desperate concern about what other people are thinking. Here it is, my novel. I'll be interested to hear your compliments. There's a secret belief that if a transcendent stage of flawlessness could be reached, maybe you'd finally get that parental approval, that esteem that you feel you lack. And often you hear it in the childhood history, there's a conviction that they just didn't try hard enough. And there's a feeling as an adult chronically, I'm not doing enough, I should do more. You hear that a lot in the therapy sessions. And they never get the response they need. It's always good dog, never great dog. That's one of my favorite cartoons. I have a 4-year-old basset hound at home. His name's Ralphie, you know, and he always has this terribly droopy face. And so I tried saying, great dog, and he still looks just as, droopy and depressed as always. It didn't help, but maybe with people it would help. Now, the workaholic tendencies are related to an unconscious conviction that love and approval can be obtained only through heroic efforts. Something extraordinary is necessary, when really it may be just something good. And this is part of the tragedy, too. Here's another good New Yorker cartoon I want to show you. The baseball player says, that ought to shut my mother up. And then mother says, big deal, this is a home run hitter's ballpark. So even hitting a home run doesn't impress mom. Here are the typical defenses of OCPD. Obviously, intellectualization, isolation of affect. These are the ones, very data-focused, non-emotional. Undoing. Where you see undoing a lot is in therapy. If the patient thinks they've accidentally hurt your feelings or been aggressive, like I said to a patient, I'm going to be gone the next 2 weeks on vacation, and the patient said, oh, great, I'll save some money. And then his face looked crestfallen. He said, well, no, I don't mean that I'm glad you're away, though. I like talking to you. I was just talking about the money, but not that I want you to be gone. And we had a good time sort of exploring that I would actually think that just because he was glad to save some money. I could understand that. But it was sort of like, I need to be a good boy to my therapist, That was sort of the tone. I don't want to show any aggression. And reaction formation, of course, comes in there too, to try to do the opposite of whatever negative feelings you have. The OCPD cognitive style, for those of you who are my age, you remember Star Trek, the original, with Mr. Spock, but there are many other characters now among the superheroes who also have thoroughly irrational, logical voices. And this is a mechanistic way of talking without affect. Just the facts, ma'am, just the facts. Careful attention to detail, almost complete lack of spontaneity or flexibility. And that can make them boring people. That causes them a lot of problem. Now, I mentioned earlier in my talk the psychology of postponement, which is essential for us to consider. And this is what you see in so many doctors. It's something like, well, I know I'm in medical school, they're saying to their partner or spouse or lover, and they're saying, after medical school, I'll have more time for you, but then there's residency. Now I'm in residency and I'm very busy, but in the future, we can have more time to do fun things like go on vacations, and then, they get to be a junior faculty member or in private practice. And I'm busy right now, but this is not permanent. I'll have time in the future. And pretty soon, the future has arrived and you've kind of missed the boat. Are you guys familiar with the Southern novelist Walker Percy? Yeah. Walker Percy had a wonderful quote in one of his books. I think it might be The Moviegoer. Here's what he said. Some people miss their lives like others miss airplanes. And he's talking about this kind of obsessive compulsive way of living where you're getting ready to live, you keep postponing everything. And pretty soon, your life's almost over and you haven't done what you wanted to do. You missed your life because all you did was work and worry about what other people were thinking. And things will be better in the future. You have to watch out for that kind of rationalization. And then it can lead to cynicism, disillusionment, and anxiety about the future and how it's going to, interfere with enjoyment of one's life. While there's a huge problem in that sort of thinking, and you don't appreciate the lived moment. What's going on right now. And by the way, this applies as much to female docs as it does male docs. There's kind of a myth, a stereotype that often the compulsive physician is a male, but lots of female doctors are just as prone to that kind of thinking about, I'll do this in the future, I'll do this in the future. And I've seen so many in the course of my practice. And I had a very poignant experience not long ago where a female surgeon was worried. She was seeing me for therapy, and she was worried that she just wasn't doing enough, And she said, could I bring my 13-year-old daughter in? And I said, sure. So she brought her 13-year-old daughter in, and Mom stayed out in the waiting room, and the 13-year-old came in and talked to me, a very polite little teenager. And I said, well, now, do you and your mom get along okay? And she said, oh, yeah. And I said, well, I know she's a busy surgeon. Does she have time to spend with you? And she hesitated and said, yeah. I said, what was that hesitation about? And then she said, well, it's like if we go somewhere and we're together, here's the quote she said, when I look in her eyes, it's like she's not really there. And so many physicians, when I say that, can relate to that. Your mind is still back in the hospital or the office, and it takes a lot of concentration to get right there, both for male and female parents, to try to be present, for the children. And that's one of the big struggles we all have. And fortunately, the surgeon really was tuned into this problem, and then the little girl and Mom and I talked about it, and we had a very productive session. Now, there is treatment for OCPD which works, and so it's not a hopeless thing, because a lot of people who are perfectionistic and compulsive try hard in therapy. And, there are limited randomized controlled trials, but one good one was done in Norway, because in Norway, the government pays for long-term therapy, so a lot of people can get into therapy. Most of the studies with OCPD have been in cluster C personality disorders in general. So we'd be talking avoidant, dependent, and obsessive compulsive. And just to go through this briefly, this was a rigorous study done by Fartberg, who's a well-known therapy researcher. And the whole sample of patients showed statistically significant improvements on all measures. And the cognitive therapy group did not change significantly in symptom distress after treatment, but the dynamic therapy treatment patients did. So one of the things they concluded is that some people would internalize the psychodynamic process and continue to improve as they thought about conversations with their therapist and continued to make insights. And 40% had recovered 2 years after treatment, which is a very good outcome. And so they concluded both dynamic therapy and cognitive therapy have a place, and there's reason to think that improvement persists after treatment with dynamic therapy. And just before I stop, I want to give you some tips about how you work with these people in therapy, because they're tough, even though they're motivated. But one of the things is that they're competitive. That's how they got where they are. So they would deny that they're competitive with the therapist, but their actions speak otherwise. You know, they correct, revise, pick apart what you say. And you know, I have one patient that way who almost never agrees with anything I say. You know, I'll say, now, do you remember that time you told me your mother was angry? He says, I don't think I said angry. I believe I said hostile. I said, okay, thank you for correcting me. But always correcting me so that it's a little competitive. He doesn't, you know, he won't validate what I say. Of course, they're threatened by loss of control, so they often do the obsessional over-inclusive thing to try to control you and the therapy. And you have to constantly show how that controlling, rigid style cripples personal relationships. Like I said to this guy that I was just saying, you know, you never validate anything I say. Now that doesn't really hurt my feelings, but I imagine when you're talking to other people, they feel that you're not validating what they say or not thinking they've made a helpful comment because you're always busy editing it and changing it slightly. And he kind of got the message there. Then there's this other problem. They speak mechanically, focus on data, details. They control the therapeutic exchange, and that's the, you know, over-inclusiveness. The sessions can get ritualized. They'll come right in, start in, and they'll talk for 45 or 50 minutes and stop. And this is another part. You know, they want to be the good patient, just like the good doctor. So they fence the therapist in. They're never late. They're paying the fee immediately, and they want to be seen as a good patient. I had a guy like this who was an orthopedic surgeon, and he was absolutely on time. But one time, he came in 5 minutes late. My office door was open. He came in huffing and puffing. I'm so sorry. There was an accident, and it slowed down the traffic, and I hope you're not upset. And I say, do I look upset? And he said, well, you look like you're just enjoying your book. I said, yeah, I was reading because you weren't here on time. And he laughed, and I laughed, and I said, you're constantly anxious that there's somebody out there who's going to be critical and just rip you to shreds for a small thing like being 5 minutes late. And so it was one of those events in therapy which paid off big time for him. Now, patients are also prone to thought crimes, where they think, if I'm thinking something, that's as bad as saying it or doing it, and I should be punished for that. That's the superego active again. One time, this is not a doctor, but I saw a Roman Catholic priest, and he said, now, in my theology, if I think about having sex with someone, it's exactly the same as having sex with someone. And so, again, injecting humor, I said, well, in my experience, that's not true. And he laughed with me, and he could see he was sounding a bit outrageous there. You know, it's not exactly the same thing. And interestingly, I later heard from a Catholic priest who was a friend of mine that he said that statement is not accurate. That's a twisting of Catholic theology in a certain direction. Many theologians would disagree with that. But, you know, the point is this guy was using it to make a particularly harsh superego world inside his head. Hostile or erotic material is often very uncomfortable because it involves feelings, and they'll use intellectualization. They'll deny anything like that, either angry or erotic feelings. And, of course, there's going to be a projection of the harsh superego onto the therapist. And you constantly, just what I was describing, looking at clarifying and interpreting distortions of what the therapist's attitude is, modifying the patient's self-expectations. Now, shame and humiliation are very important to keep those in mind as the feared affect states. And you have to empathize that the patient's afraid of feeling shame and humiliation when they're less than perfect. Many people who have studied shame say shame is an affect that I should be here and I'm only here. And that space creates shame. Another thing, the British Kleinian analyst John Steiner says exposure is critical to shame. Like, I am somehow exposed to people who are watching me, just back to the imaginary audience. People are seeing me and watching me fall short. And see, I try to work a lot with that. And there's a corrective emotional experience here, because you as a therapist are not jumping on them or criticizing them for whatever it is they do. And, I'll often say, what you think was a horrible mistake sounds like actually you did a pretty good job, but you can't see anything positive about yourself. To try to reverse their way of thinking. And over time, they often get that message. Sometimes it's great to bring in a spouse or partner. I had a very, solid physician in my office as an individual patient, and his male partner came in at my request again, because this guy had a feeling that he couldn't do what he needed to do, but he couldn't understand why his partner didn't respond to him better. He thought he was just, it was egocentric, because he thought he was just being a hard worker. But then when his partner came in, he said, you don't realize how you come across to me. You seem always absorbed with your work. And so there are times where at the dinner table where I feel like you don't even know I'm there. And see, what I'm doing when I bring in the partner is you're providing a mentalizing experience. My patient couldn't mentalize how the partner was feeling, but the partner can. And he comes in, and he says it all, and he's sitting there, and I'm kind of a mediator. I say, see, this is how you're coming across. You don't know that. And so bringing in someone else helps so much in these cases. So that's something you always want to keep in reserve. And you get an objective view that supplements the subjective view of the patient. Now, there are specific countertransference difficulties that we're all going to have, because many of us rely on the same defensive repertoire as the patient. As I said at the beginning of this lecture, this is also about us and what we do. And one of the things we do is use intellectualization, isolation of affect, perfectionism that haunts us too. And it's so easy to get sucked into competitiveness, because they'll come on and competitive. Like one of my patients walked in and said, I was thinking about Dante. Do you remember the opening lines of Dante's Inferno? And I kind of froze, sort of like I was back in school, and somebody was asking me, recite the opening lines of Dante's Inferno. And I thought I knew them, but then I thought, wait a minute, what if I'm wrong? So I didn't say anything. It took me about 5 seconds to sort of recognize the countertransference and kind of work out of it and say, are you testing me? I mean, don't you already know the opening lines to Dante's Inferno before you're asking me? He goes, yeah, I just wanted to see if you knew them. I said, well, that's what I thought, but therapy is not about testing me on my memory of Dante. So we kind of laughed about it, but that kind of competitiveness is there lots of times, and the therapist can have the same perfectionistic strivings with patients. We can expect too much of our patients because of our OCPD stuff. Here's another very important countertransference difficulty. I think when we treat physicians, we have a kind of narcissistic vulnerability, where am I going to show myself as not good enough to treat this very intelligent, respected physician. And then you can feel chronically devalued when a physician with narcissism and OCPD constantly is putting herself or himself above you and trying to talk down to you, because that's the defensive technique they're using. You know, I'm above you, I don't need to be intimidated by you. So you can feel devalued about, you know, they often name drop and will talk about, you know, famous people they know and talk to, and they'll say, oh, do you know that person? No, I don't know. This kind of comparison. And of course, the ritualization of sessions can really produce boredom. Now, one of the things that I teach all my residents is that no matter how good you are, at some point in your practice, you will have trouble staying awake. So you don't want to fall asleep on a patient. So there's two things you can do. One is you have a bottle of water and you put it away from your chair on your desk or something. And then you have to get up and walk to get the water. Another one is that you could have your appointment book somewhere else. So you have to get up. But there's a wonderful technique that I use when I start to get bored or sleepy. Neville Symington, the Australian analyst, put this in one of his books. I say to the patient, you know, sometimes when you speak, I have the impression that you really don't expect me to be interested in what you're saying. But remember that works like a charm, because it's usually right. You know, someone is droning on and they don't really care if you're interested, but it brings it quickly into an interpersonal setting and not someone just reciting, you know, a soliloquy. Termination of these people can be complicated because therapy always ends perfectly. Nobody is perfectly analyzed or therapized. No one completes therapy. We get them started. A process has begun. And then the patient continues after therapy with their own kind of self-analytic work. But the patient has to accept that they'll be imperfect when therapy stops. I talk about this early on in therapy usually. And I say, you know, when someone leaves, the door is always open for return if you need to work on some other issues. Now, here are my final thoughts, and then we'll have time for discussion. I want to give you some statistics. Doctors in the United States are the lowest in terms of vacation days, 14 per year in one study. In the UK, it's 26 per year. And of course, in France, it's 37, as you might guess. But we are kind of hard on ourselves in terms of how much leisure time we take. And some of the things I want you to think about that I've thought about during my career is the William Saroyan play, The Time of Your Life, in which he says, in the time of your life, live. And that's a very simple statement, but one that a lot of people ignore. They don't take time to live. All they're doing is doctoring. Don't be enslaved to an imaginary audience, because that audience, like I say, is probably thinking of themselves more than you. And do what you want to do now. You know, the carpe diem. There's so many postponement strategies that we use where often we wake up one day and we're too old to do what we'd like to do. And how you spend your time is critically important. Think about those you love. Be picky about how you spend your time and what sort of boring thing that you're doing out of obligation when you'd rather be with someone you love. And if you go forward with that attitude as you all graduate from the residency and you get into practice and fellowships, keep these ideas in mind as a way of reminding yourself every day what's really important and what's not so important. I'll end with a wonderful quote by Epicurus. The fool, with all his thoughts, has this also. He is always getting ready to live. Thank you.
That was a wonderful presentation, and there's time for discussion, questions.
What a wonderful talk. Thank you so much, Dr. Gabbard. So one of the things I was wondering is that physicians that you've treated have experienced some sort of trauma or some things where sometimes they have OCPD addiction or something else or a second victim impact, do you sort of address the crisis first, or do you start working on
Sure.
OCPD?
Yes, I would say good practice is to deal with the crisis first, the acute, and often it is a devastating narcissistic injury, like a mistake they made, a lawsuit where they feel I wasn't perfect, and that you can focus on that as you go about the high expectations, but you start with how can we help with this crisis to make it a little more manageable, and what are you doing, what strategies have you already tried, and to be very supportive, and get more into exploration of the psychological issues a little bit later when they're settled and you have a good therapeutic alliance established. All the psychotherapy research literature says the most powerful predictor of outcomes is the therapeutic relationship. If you have a good alliance with that person, you're likely to have better outcomes. So you work hard to be supportive and form that at first. Yes.
Thank you, sir, for this lecture. Is there any factors which change COPD to OCD?
Are there any factors that change OCPD to OCD? Now, I'm not aware of any. There could be cases, because we know there's some with both conditions, but I don't know if there's a specific factor that leads, or precipitate that leads from one to the other. Yes?
I was intrigued earlier when Dr. Crystal mentioned you'd written about near-death experiences, and I was wondering if you've seen near-death experiences having any impact on people with OCPD.
It's a good question, not specifically with OCPD, but in the research on near-death experiences, it is true that it's one of those experiences for a lot of people that transforms their lives. They feel like they see life in a different way because they almost died. And I would think if one was OCPD and had a near-death experience, it might work that way. At least there'd be a temporary effect. They might go back to the old habits, but there's some really good research on what happens to people after they realize they almost die. Got to live in the moment more. Yes.
Thank you so much for such a great talk. All of a sudden I feel very forgiving of myself. So.
Good. That's what I was hoping would happen.
I was curious if you noticed any trends or patterns between specialties. Or is one specialty more likely to come with OCPD traits and see you versus another?
I don't think so. And, when we used to have the Colorado workshops, there would be lots of debates where the medical subspecialties would say, we're the most obsessive compulsive, but the surgeons in the group would say, no, surgeons have to be more compulsive, have to be so meticulous. And it was almost a badge of honor to be more compulsive. But I think it could happen almost in any specialty. And I'm now at this stage in my career very reluctant to sort of offer off-the-cuff percentages of who's likely to be more compulsive, because it's just across the board. And I actually get a little worried if I would see a doctor that has no compulsiveness, because you wonder, are they really going to check what they need to check carefully, and would I want to go to that person? So that's the paradox of all this. It's not making it go away, it's decreasing it. Yes?
So you opened your talk with a seasoned physician who gave up his license and became suicidal in the context of this loss of his identity. And given the rash of highly publicized young physicians who have committed suicide early in training, especially more recently, I was wondering if you had any thoughts about earlier interventions, especially in the psychodynamic framework for residents and interns who maybe aren't so psychologically minded at that point in their careers.
Yeah, it's a real good question, and it's just heartbreaking to see the number of suicides among trainees, basically. Now, we have to study that thoroughly to see what was really going on in those cases, but we can assume that some of it was perfectionism, and we know there's a link between perfectionism and suicide. Now, yes, there ought to be some kind of systematic prophylaxis, a preventive measure that could be part of medical training. And yet, the whole problem is, and gets back to the problem of burnout, that people know that they might burn out, but if they take time away from their work to try to relax, they think they're being a slacker. and they'll get chewed out by somebody who's, you know, on the faculty or somebody that will feel like, I'm doing your work while you're gone. And I remember at Mayo, they tried having as part of a prevent burnout effort, they had a time in the day where you could come to this room and do yoga, breathing exercises, some exercise. Nobody was showing up, you know. It's like, you can say we should be doing this, but most people will say, man, I'll get behind in my work. And so I just can't do that. But something like that ought to be implemented, you know, for everybody. And, you know, meditation, mindfulness has a real good built-in way of decreasing the stress and perfectionism and being more realistic. Things like that, but it's hard to get people to do it. I wish I had the answer. Yes?
One of the seductions of evidence-based therapies is that it offers strategies or techniques for doing things. And some obsessive-compulsive patients, their real goal is that you should give them strategies so they can be a better compulsive.
Yeah.
How do you handle that? You know, you're not telling me how I can really get caught up on my work.
Yeah, and I would say this is the problem, though. You know, is the way you're thinking about it is, how can I stay the same, not change, but do it better? And you just have to confront that directly, because I've seen that. I know exactly what you're talking about, and they think you'll have tips on how you can get more done in 24 hours. But it's not, I just confront them and say, that's not gonna work. Other questions? Yes.
So, with is there any link with between obsessive compulsive personality disorder and maybe more vulnerability to a trauma-related disorder after exposure to a criterion A trauma, kind of given the tendency to overthink things and expect perfection to begin with?
I haven't seen any research on that, but I certainly have seen it in the office, that somebody who has some kind of trauma thinks this way if they're OCPD. You know, I was doing everything right. This shouldn't have happened to me, you know. I'm so careful about everything. I can't imagine how I could have this traumatic experience, this car accident, or getting stuck up, or whatever it might be. You know, this shouldn't happen. And there's a fantasy. I'm almost perfect now, so I can avoid bad things happening to me. And that's what you would work on in the therapy. Yes, in the back.
In your talk, I was making notes when you were saying that obsessive compulsive personality disorder people like to make notes. So, have you had any experience with implementing corrective emotional experience? This is connected to the comments that physician suicide and burnout at the healthcare setting, because without any, there's no way for people to have any alternative way of knowing that they are doing a good job, except this imaginary person that had perfect control of all 10 patients and with like complicated illnesses, like just some sort of group validation.
Yeah, well, the American Psychiatric Association has got a program going right now to help burnout. And there are some very smart people involved with that, and they're trying to set up programs in most residency training to help focus on it. But what's, like I said before, a lot of this is relegated to lesser importance than the other things you have to do, so that many obsessive compulsive residents would think, this won't ever apply to me. I'm doing things so well that that's not going to I won't let that happen to me. So there's a fantasy of invulnerability that gets in the way of implementing programs so people will actually follow through. And then you might make them mandatory, and people would kind of sit through them and look at their iPhone and not pay attention too, you know. You have to sort of have a personal experience of suffering to recognize the need for it. Because remember what I said, OCPD has predominantly egocentric phenomena. You know, all the hard work is thought of, this is being a good doctor, this isn't a problem I need to address. Yes.
Sort of a follow-up to the evidence-based question. So electronic health records do a lot of good things, but do you think, I mean, so in some ways, like the focus on like population outcomes and data, that idea of like the activity itself becomes more important than the rationale behind it. an example I'll give you is a team meeting I was at earlier this week where we were talking about someone who's alcoholic and was lost to therapy, and the sort of pedantic, rigid nurse said, well, in the intake, we forgot to screen if he had hepatitis. We have to track him down to find out if he had hepatitis. Well, we're just figuring out whether he's lost to treatment. And what do you think that these EHRs can really foster compulsive, make it worse?
Oh, absolutely. You know, and there was a whole issue of Pharos, the AOA magazine, devoted to the problems, you know, with the electronic mental health records, or health records in general. But, you know, I think I understand the rationale for them, but I do think they shift a doctor's value system. Like, okay, I've got 15 minutes here with this patient. I can't make eye contact because with the patient, you know, but go ahead and tell me your history. I've got to get the record in. If I can get this record in 15 minutes, then I can get home for supper, you know, and it's like, there is something about the doctor-patient relationship that gets lost in the concentration of getting the record just right. And the record, the electronic healthcare record itself is a kind of obsessive compulsive activity, isn't it?
Yeah.
Getting it just right with numerous questions that seem peripheral, and it drives everybody nuts. So I have real concerns about the future. I think we're stuck with it, but it is going to change the practice of medicine and psychiatry to some extent.
What about addiction risk in OCPD? In other words, if people are not tied into their emotions and are out of kind of unable to use social relationships to help manage those emotions, are they prone to use substances to
Well,
do that?
I haven't seen good data on that, John, but in my experience with it, I can tell you this, that a lot of obsessive compulsive people, because they're perfectionistic, don't want to go near drugs. You know, they want to say, I'm above all that, and I'm not going to have anything to do with drugs, although I have seen a number of them who drink at the end of the day to try to get themselves somehow keyed down, and they do develop alcohol problems that sometimes requires, you know, going to a residential setting. So I don't know the data, but it seems that alcohol is more of an issue than drugs for the ones I've seen. Yes?
Thank you for bringing your considerable humor and theater experience to the presentation. I was wondering if you had any comments about the arts in the theater and its role in physician life.
The art of the theater and
Yeah, and
Well-
like how it ties in with, say, treatment of OCPD or.
I haven't really used it in terms of any kind of treatment, although certainly there are, you know, there's getting people to attend theater would be a way of trying to get them out of the grind of work all the time and figuring out, you know, and there have been many physician playwrights like Chekhov and others, and there are plays that would be worth seeing, but I don't know how that would be done systematically. But once in a while I've recommended to a patient that they ought to see a particular production of something. Yes.
How about one last question?
Yeah.
Thanks for a great talk. That is a good talk with a great talk.
Thank you, thank you.
I've seen the therapy dog in the medical library and from the law school as well. Is there any information about the use of animals in that way?
Well, I mean, like I say, I have dogs at home, and dogs can be very therapeutic, no doubt about it, and kind of let you sort of become less stressed by the time you get home and you're petting your dog. My wife says dogs teach you how to live.
It hasn't been found in study, I guess. Is there any evidence? Is there any studies of that?
There must be, I haven't looked at that literature, but there must be studies of dogs and their effect on stress.
Well, thank you so much for a wonderful.
Thank you very much.